Welcome, welcome. On behalf of Women's Health Advocates, thanks for joining today's virtual congressional briefing, the Menopause Policy Imperative, Shaping the Future of Women's Health. I'm Beth Garner. I'm a women's health physician by training. I transitioned 20 years ago from clinical practice to industry, specifically to address unmet needs in the health of women. I'm currently the CEO of Cinna Therapeutics and a founding leader of Women's Health Advocates. WHA is the first and only professional lobbying organization educating and advocating for the health of women throughout the lifespan from head to toe. We are uniting people to educate government decision makers on policies and funding needed to advance the health of women. Our members are industry and nonprofit leaders, investors, entrepreneurs, researchers, clinicians, patients, and others. Areas we focus on include menopause, bone health, brain health, cancer, heart disease, and many more. All of our policy recommendations are evidence-based, and our leaders have also launched issue-based advocacy initiatives to shape policy as well as regional events across the country. So why are we here? Well, we're here today because 75 million American women are currently in the menopause transition, with approximately 6,000 reaching menopause every day. Yet despite affecting half the population, menopause remains one of the most under-researched, underfunded, and overlooked areas of healthcare. Women can experience 40+ symptoms and face increased risks of osteoporosis, heart disease, cognitive decline, Alzheimer's disease, and other chronic conditions. The impact extends far beyond individual health, affecting workforce participation, productivity, families, and communities. So during this briefing, leading experts and advocates will present the case for why we need more public awareness, clinical education, and research. We will share a list of bills that would help close these gaps and tell you how to champion them forward. Just a couple of things on logistics. Please put your questions in the Q&A. We will share the slides, the recording, a summary of the menopause legislation pending, and responses to questions in the follow-up emails after the briefing. So I'm excited to say that our first speaker is Congressman Julia Brownley. As a first speaker, like I said, a champion for menopause care for women. Congressman.
Thank you for allowing me the opportunity to join you in the Women's Health Advocates community for today's conversation about menopause. For too long, perimenopause and menopause have been dismissed, ignored, or shrouded in stigma. The cost of that silence is enormous, and higher healthcare expenses, lost earnings, and reduced productivity for women and their families. Almost all women entering midlife will go through perimenopause and menopause. We need a better understanding of how this impacts health, better resources both in and outside of our healthcare system, and better results in addressing symptoms that 80% of women experience during this stage of life. Like so many women, I've gone through menopause myself. I've experienced the symptoms. I know how disruptive this transition can be. That's why I introduced the Improving Menopause Care for Veterans Act of 2025. As the ranking member of the Veterans Affairs Committee's Subcommittee on Health, I see firsthand the challenges our veterans face, and I know we can do better in providing menopause and midlife women's healthcare services. We owe it to our veterans to do better. The VA serves nearly 2 million women veterans, and women veterans age 45 and up are the largest single demographic in the women veteran population. With the growing demand for menopause and the midlife women's health care, we need to ensure VA's readiness to deliver this specialized care. My bill calls for a study on current care, guidelines, education offered to veterans, and how the latest research is being incorporated into the care provided. My bill also directs VA to develop a strategic plan based on the study's findings and implement the recommendations to improve the quality of menopause and midlife women's health care provided by VA. I want to ensure that women who have served our country can age with the dignity and care they deserve. And I want all women to thrive through midlife and beyond. We need more investment in research and better education for patients and providers that recognize this reality. And above all, we must elevate women's voices and experiences in the doctor's office, in the workplace, and in the halls of Congress. Thank you all for your efforts to educate and advance policy to improve menopause and midlife women's health care for veterans and women across the country. For far too long, women have been told to suffer through menopause in silence. That must change. And real change begins with conversations like this one and with advocates who are willing to speak up, challenge outdated assumptions, and demand better. Thank you for helping lead this important work. Together, we can ensure every woman receives the care, respect, and support she deserves.
Thank you, Congresswoman Brownlee. And we will share with everyone how they can support the Improving Menopause Care for Veterans Act at the end of this briefing. I'm Lisa McDonald, Director of Policy and Advocacy at Dr. Mary Claire Haver's The Pause Life, a leading voice in menopause education, advocacy, and awareness. We have an incredible panel of experts who I will introduce as their topics come up. First, we'll welcome Dr. Mary Claire Haver, founder of The Pause Life and the Haver Family Foundation. She's a board-certified OBGYN, New York Times best-selling author, and host of the podcast Unpaused. While unable to join us live today, Dr. Haver has shared this video.
I'm Dr. Mary Claire Haver, board-certified obstetrician gynecologist and certified menopause practitioner. I'm also an adjunct professor of obstetrics and gynecology at the University of Texas Medical Branch. So what is menopause? And that is a great question. Menopause medically is defined as 1 year after a woman's final menstrual period, but it actually represents something a lot more complex than that. Human females are born with their entire egg supply. And by the time we are 30, we are down to about 10% of that egg supply. And by the time we're 40, we're down to about 3% of the original egg supply. And menopause represents the end of our functional egg supply. And when those eggs run out, the ability for us to produce the hormones that we relied on for the last 40 years goes with it. And those hormones are estrogen and progesterone. Females also have testosterone, which is a very important hormone, but that declines with age across the lifespan, just as it does in a male. But what you may not realize is we have estrogen receptors in every single organ system of our body. And estrogen is critically important in our brain health, in our cardiovascular health, in our musculoskeletal health, as well as our genitourinary health as well. I am a classically trained obstetrician gynecologist, and I went through 4 years of medical school to get my MD and then 4 years of an OBGYN residency. In medical school, if I think hard enough, I think I had one 1-hour lecture on menopause. This is something that affects 100% of women and affects the last 30 to 40 years of her life. And then when I specialized in women's health, we had 6 1-hour lectures in a 4-year curriculum. This is not the fault of an individual clinician. This is a systemic problem. We are not mandating training in women's health after reproduction ends in most of our clinical training programs. Menopause affects our workforce. It affects our longevity. It affects our economic and healthcare costs. We should support policies that fund aggressive menopause research, that encourage doctors to be educated and that increase awareness so women everywhere can actually get the care that they deserve. This is really the message of the briefing. And I'll leave you with this. Women live longer than men, but women can expect to live 20 to 25% of their lifespan in poor health compared to their male counterparts. Women are 3 times as likely to develop Alzheimer's dementia, as well as to be diagnosed with frailty and loss of muscle mass. They have much higher rates of osteoporotic fracture, which lead to disability and the very difficult last 10 years of their life. I really believe that with the right support, we can reverse these trends and allow women to live as healthy as they deserve for as long as possible. Menopause is not the end of fertility. It is the most predictable acceleration of aging in the human body. The diseases waiting on the other sides are the ones that kill and disable women the most: heart disease, Alzheimer's dementia, osteoporosis, and diabetes. Half the population walks through this. And what do we do with it? We filed it under women's health and stopped paying attention. We treated a longevity event like a lifestyle phase. Women are owed centuries of research. That has not come. This is not only a woman's issue. When women move through this transition healthy, we protect brains, hearts, and bones at scale. We save the healthcare system billions of dollars. Everyone benefits when women are well. Everyone. Their partners, their children, their families, their coworkers. The menopause transition may be the clearest window we will ever have to slow brain aging, protect the heart, and save our bones. And we are walking right past it. We need research, we need funding, and we need to prioritize women's health outside of reproduction.
Thank you, Dr. Haver. As Dr. Haver said, menopause has implications for our economy, our productivity, and our long-term healthcare costs. Yet in the United States, we tend to treat menopause as a personal issue, a private struggle, instead of a public health and economic issue. That is a mistake. Menopause is costing this country. The Mayo Clinic conducted an analysis of the annual cost of menopause to the United States and found $1.8 billion in economic costs from missed workdays due to severe symptoms. The study noted this is actually conservative because it doesn't even account for reduced work hours, reduced productivity, job changes. So it's likely that the economic costs of menopause to the workforce are even higher. And to give you some context for this figure, 20% of our workforce, or about 27 million women, are currently in some stage of the menopause transition. So this is 1 in 5 workers moving through a health transition that workplaces and healthcare systems are not adequately supporting. The study also found $24.8 billion in direct medical expenses, the costs of managing and treating symptoms like hot flashes, joint pain. But this figure also underestimates the full burden. It can't account for the cost of conditions that accelerate during menopause and that worsen without proper treatment. Conditions like osteoporosis and the genitourinary syndrome of menopause. If we could calculate these costs, we would find the total economic and healthcare burden is far higher than $26.6 billion a year. So what are these other costs? Because menopause increases health risks to so many systems of a woman's body, you heard Dr. Haver say we have estrogen receptors on every cell. Menopause is actually a window of opportunity to identify risk early and prevent downstream diseases and their associated costs. I'll give you 2 examples. The first is bone health. Within the first 5 years of menopause, women can lose up to 20% of their bone density. This increases the risk for osteoporosis. Half of all women will experience an osteoporotic fracture in her lifetime. And in the Medicare population alone, more than 2 million fractures cost the nation $57 billion a year, with women accounting for about 80% of that number. Osteoporosis is a largely preventable condition, and if we use the menopause transition as a window of prevention, rather than waiting for a fracture to occur, and what that means is assessing women early for their risk, not waiting till they're 65 to assess their bone density, which is essentially what we do now. If we did this earlier, we could save billions in downstream costs and prevent harm for millions of women. The second example, the Menopause Society estimates that up to 84% of menopausal women experience GSM, with symptoms that include recurrent urinary tract infections, associated hospitalizations, sepsis, and in some cases, death. But GSM can be prevented and treated with low-cost vaginal estrogen, yet less than 10% of women use it. Without this treatment, GSM is chronic and progressive. It's been estimated that Medicare alone could save up to $22 billion a year if the Medicare population were given vaginal estrogen. So these are two largely preventable conditions. And if managed during the perimenopause and menopause transitions, we could save our country billions in annual expenditures. There are even more risks that accelerate during menopause, such as cardiovascular disease, diabetes, and if we assess these risks during menopause, we could help prevent disease and save even more. So it's very clear we need to educate the public and clinicians to treat this period as a window of opportunity for prevention. So we've talked about the costs of menopause. Let's hear more of a personal story from Tamsin Fadal. Tamsin is an Emmy Award-winning journalist, the producer of the menopause documentary, The M Factor, a New York Times best-selling author, and host of the Tamsin Show podcast. Thank you, Tamsin.
Lisa, thank you so much, and thank you all for being here today. For 30 years, I worked as a television journalist and a news anchor. My job was to really understand complicated information quickly and stay calm under pressure and then find the right words. In my late 40s, though, something totally changed, and I had no idea what was going on. I would look at a word on the teleprompter. I knew a word, I couldn't say it, and I could see it, I understood what it meant, but it wouldn't come out of my mouth. And at the time, I had no idea what was going on. I never heard the term brain fog, which we now know is one of the common symptoms of perimenopause and menopause. And I quietly believed I was losing my ability to do the one job I'd spent my entire career learning how to do. I went from doctor to doctor, but nobody connected the symptoms, and no one ever said the word perimenopause. Eventually, I learned I was in menopause through a short message in my patient portal. 4 words: in menopause, any questions? And that was it. As a journalist, but more importantly as a woman, I had a lot of questions. And the biggest one was this: how could I have spent decades reporting on every health issue under the sun or every new study and be completely unprepared for something I knew was going to affect the entire half the population? And I knew I couldn't be the only woman asking those questions. So I started doing what I had done my entire career as a journalist, and I started asking the questions. And my community grew online into the millions as I spoke with physicians, with researchers, with women all across the country. And the more questions I asked, the clearer it became that this was not just my story. It was a massive gap in our healthcare system, which is what we're here to talk about today. 2.5 years ago, I walked away from the news desk to help find some answers. I've since then produced 2 global documentaries about menopause and perimenopause with a team of women. And those films have been seen across the world because women need help. And every time they come to us, they say they don't know where to go to find it. Today, though, despite all the progress I feel like we've made, too many women are still suffering in silence. They're being told it's stress, they're being told they're too young to have symptoms, or to lose weight, or to get more sleep, or just try to relax. It's actually ridiculous. They're being prescribed medication for anxiety or depression without anybody ever asking whether or not hormonal changes are taking place. Some women spend years searching for answers. I was one of them. A few weeks ago, in fact, I interviewed Melinda French Gates on my podcast, and even with all her resources, she had to see 3 doctors before she got the care she needed for perimenopause. Some women I've talked to told me they've just stopped looking for help. Others can't find a doctor who understands menopause care at all and can't get the treatment covered, or both. And when I look at it, it's not only a health story, it's a career story. When I looked at those words on the teleprompter and I couldn't recall them, I didn't think, maybe this is menopause. I thought, what if I can no longer do my job? Women across this country are asking themselves that question every single day. As Lisa said, right now, there are approximately 27 million women in our workforce who are in some phase of the menopause transition. We cannot afford to treat the health of 1/5 of the workforce as a niche issue. Many of these women are right at the height of their careers, and they're dealing with symptoms that interfere with their sleep, with their memory, with their mood, with their physical health. The Society for Women's Health Research found that 1 in 4 women has considered leaving a job because of menopause symptoms. It's just not acceptable. And the estimated cost of missed workdays alone is $1.8 billion every year in the US. But to me, the cost is a lot larger than that number. It's the woman who turns down a promotion because she no longer trusts her memory. Or maybe it's a physician who cuts back on her hours because she can't sleep at night. Or the teacher who uses every ounce of energy just to get through the school day. There is something that gives me hope, though. We're not starting from zero. We have evidence-based hormonal and non-hormonal treatments out there. We have millions of women who are ready to take an active role in their health. But the gap is not simply whether knowledge exists. The gap is whether that knowledge reaches medical schools, examination rooms, insurance plans, and then the women themselves. And that's why the legislation being discussed here today matters. These are not abstract policy changes, and as a journalist and advocate, I know how much it takes for a woman to become her own medical investigator. These women shouldn't have to risk their careers before they receive an explanation, and they shouldn't have to be wealthy or well-connected or lucky to find appropriate care. We have an opportunity right now to build a system so the next generation of women entering this transition, they come into it informed and supported and able to receive care. Congress has the power to help close the distance between what medicine knows and what women actually experience. And the thousands and thousands of women I hear from every day are ready for it, and so am I. Thank you.
Thank you, Tamsin. So many women share your story of suffering, so it's important to bring these stories to light. So now we're going to hear from Joy D. Calloway, President and CEO of the Black Women's Health Imperative, the first nonprofit created by Black women to help protect and advance the health of Black women and girls. Thank you, Joy.
Thank you so very much. Anything with imperative in the title is right up my alley. Imperative, essential, urgent, absolutely necessary, obligatory. Menopause policy, my friends, is imperative. Menopause is universal, but equitable menopause care is not. All women will experience menopause in some way at some point, but what that universality does not mean universal experience in menopause care. For millions of women, accessing timely diagnosis, evidence-based treatment, and knowledgeable providers remains unnecessarily difficult. Studies show that Black women experience menopause earlier, more severely, and for a longer period of time than any other racial or ethnic group study. Per one study, Black women were 18% less likely to have their menopause symptoms documented and 26% less likely to receive menopause hormone therapy than our white counterparts. At the Black Women's Health Imperative, we understand menopause represents one of the greatest public health opportunities to improve women's health across the lifespan and one of the clearest opportunities to advance health equity. Next slide. For Black women, menopause is rarely experienced in a vacuum. It often coincides with cardiovascular disease, hypertension, diabetes, obesity, and other chronic diseases that disproportionately impact our communities. These inequities, to be clear, did not start with menopause, but menopause can and does expose and magnify them, making midlife one of our greatest opportunities to improve long-term health. That's why we believe that menopause is about far more than reproductive health. Menopause is a healthy aging issue, a workforce issue, a public health issue, and ultimately a health equity issue. Know this, menopause doesn't just impact women's health, it impacts America's economy. Next slide. Women today spend between 1/3 and 1/2 of our lives after menopause. These are often our peak earning years, our peak leadership years, and the years in which many of us are balancing careers while caring for our children, our aging parents, and being active in serving our communities. Yet, this is the time when our bodies and our brains seem to go haywire. When women cannot access timely diagnosis or evidence-based care, the consequences extend far beyond our individual health. They affect workplace productivity, career advancement, workplace participation, retirement security, and family and financial stability. All of these things which impact our economy. Next slide. You've already heard about the 1.8 billion, but when you consider absenteeism, reduced productivity, turnover, healthcare utilization, and lost advancement opportunities, the true economic impact is even greater. And for Black women, these consequences can be especially profound. Many of us are most likely to be the primary or co-breadwinners of our families and disproportionately represented in essential professions, healthcare, education, caregiving, public service. Did you know that Black Americans command more than $2.1 trillion in buying power, and that Black women control the lion's share of that spending while serving as key household decision makers? When menopause care falls short for us, that ripple effect is felt by our families, our employees, our community, our employers, and our economy. Menopause doesn't just affect women's health, y'all, it affects America's economy. Investing in equitable menopause care strengthens our families, it supports a more resilient workforce, and it builds a healthier nation. Fortunately, next slide, we know what works. Building equitable menopause care requires four intentional investments. It requires investment in menopause research. Broadly, yes, but also in such a way that the evidence guiding clinical care reflects the real lived experiences of Black women and other historically underrepresented populations, not just those populations who have been traditionally included in clinical research. It requires investment in menopause education, so healthcare professionals are prepared to recognize menopause and not dismiss our symptoms. They're prepared to communicate effectively, deliver evidence-based, culturally responsive care, and the full array of interventions and supports. It requires investment in access to menopause care so every woman can receive high-quality, evidence-based menopause care regardless of where she lives, what she earns, or what insurance card she carries. Scientific advances only matter if women can benefit from them, if they can find them, if we can reach them and use them. And it requires investment in menopause policy because policy strengthens education, it expands access, and it helps ensure the benefits of scientific progress reach every community. These are not four separate priorities. Together, they form the foundation of equitable menopause care. The bipartisan legislation being considered by Congress reflects this understanding. It recognizes that improving menopause care requires more than just raising awareness. It requires sustained investment in research, education, access, and policy so that every woman can benefit from advances in science and medicine. Last slide quickly. Just closing, know that at the Black Women's Health Imperative, we recognize, we understand, and we activate all four of these critical priorities. In research, we conducted the largest cross-sectional survey of U.S. Black women aged 30 and older on menopause. I invite you to our website to find out those results. In education, we have an edutainment series called The Power of the Pause, which brings together Black women, healthcare professionals, community health workers, and employers to talk about this work. In access, we serve as the trusted voice, messenger, and national convener and healthcare information hub to beat back some of the myths and disinformation about menopause in the marketplace so that we can help ensure that evidence-based menopause care reaches women who need it most. And finally, our 25-26 policy agenda prominently highlighted menopause care. We amplified this priority by doing what we're doing today, advocating for the healthcare needs of Black women and girls, educating and informing policymakers, payers, and administrators. We know that the true measure of progress is not whether some women benefit from advances in science, it's whether every woman has the opportunity to benefit. Thank you for your time.
Thank you, Joy. Really, thank you for all that you and the Black Women's Health Imperative are doing. And we couldn't agree more. Menopause policy is indeed an imperative. So now we're going to hear from Dr. Sarah Berg, board certified OBGYN and founder and CEO of Selfority, a women's health platform that helps women become their own best advocates through menopause education. Thank you, Dr. Berg.
2. That's how many lectures on menopause I had in 8 years of training to become a board certified OBGYN. 4 years of medical school, 4 years of residency, and I'm the person in the room you'd expect to be the expert on menopause. 2 lectures. Different school, different residency than Dr. Haver, and we were failed in the same way. Because the failure isn't personal, it's structural. Only about a third of OBGYN residency programs offer any form of formal menopause curriculum. And the programs that do offer 2 lectures a year. And across different residency programs, family, internal medicine, OBGYN, 1 in 5 residents finishes training without a single menopause lecture. That lack of focused training is a big reason why 6.8% of clinicians feel they were not prepared to care for women in menopause. And looking at the above statistics, I'm actually surprised that percentage is as high as it is. Now, the menopause training I do have, I invested time, money, and effort to earn after my formal education was done. The system did not make me a menopause competent physician. Like the other clinicians, who have the menopause certificate, I took the initiative to fill the gap the formal pipeline left wide open. And very few of us do. There's roughly one certified menopause practitioner for every 30,000 women who need one. For comparison, this country has more certified cancer specialists per capita than certified menopause specialists for a transition every woman will go through. Patients pay the price for that gap. But it's more than the fact that menopause is barely taught. What little training clinicians do get is shaped by fear. In 2002, a large federal study called the Women's Health Initiative, or WHI, was stopped early and abruptly due to reported risks with menopause hormone therapy. The FDA put a black box warning, they're most serious on estrogen, for heart disease, blood clots, breast cancer, and dementia risks. The findings weren't wrong, but they were stripped of context. They applied to all women at every age as a blanket warning, when the real risk was far narrower. The fear was immediate and total. A generation of physicians was instructed to keep women away from a treatment that for many of them is safe and effective. Over a decade ago, I was trained in the shadow of that study. So is the physician who finishes their residency this year. Just months ago, the FDA removed the warning because the science never supported it the way we were taught. That move corrects the label. It does not retrain a generation of clinicians. And this isn't only a gynecology problem. Women often see many specialists looking for answers. Let me show you. I'll call this woman Linda. She's a composite of women I've treated, and I promise you, every physician in this room has sat across from her. Linda's 49, she's a mom, she's a wife, and a teacher. She walks into the cardiologist because her heart is racing. She walks into the neurologist because she can't find her words in front of a classroom full of teenagers. She walks into a psychiatrist because of unfamiliar anxiety. She goes to the urologist for recurrent urinary tract infections. And finally, she walks into primary care where she's handed an antidepressant. 4 years of searching and frustration. Not one of the doctors said menopause. Each treated the symptom in front of them with the training they had. The problem is none of them were sought to see the racing heart, the brain fog, the anxiety, the UTIs were not separate problems. They're one transition. Those 4 years cost Linda. They're the years when a woman's long-term disease risk gets set. Her bones, her heart, her metabolism, etc. Catch it here and we could change the trajectory of her life. Miss it and she spent her last decades managing diseases we could have gotten ahead of. Linda lost bone she'll never get back. Her cardiac risk climbed unwatched. Her UTIs recurred and she became resistant to antibiotics that previously worked. She paid for scans she didn't need and missed ones she did. And there's a second thing those 4 years took from Linda, and it's quieter. She finally said the symptoms she was most afraid of out loud, and her doctor didn't recognize it. She left the visit feeling brushed off, ashamed she had said anything at all. So she stopped telling her doctor the full truth and started going to the internet, to her friends, and whoever would finally seem to listen. And Linda's not unusual. A quarter of women between 50 and 65 have never been told by any doctor they were in perimenopause or menopause. Almost all of them have symptoms. If this sounds like your wife, your sister, your mother, yourself, it probably is. Now, say we win that fight and every physician is trained, we would still have a problem because a trained physician cannot deliver care the system won't make room for. A menopause visit is not quick. It's a complex, connected, whole body assessment, a conversation about the factors that shape the next 30 to 40 years of her life. That takes real time, more than the 7 to 15 minutes most physicians are allotted for an appointment. So physicians face a choice, do it right or keep the practice open. Many stop taking insurance, not out of greed, but because stepping outside of it is the only way to buy the time they need, which is not fair. And this isn't only her problem, it's ours. Inappropriately treated menopause costs this country about $26 billion a year, as you heard from Lisa, in medical bills and lost work. We're already paying for it. We're just paying for it in the most expensive way possible. After the fracture, after the heart attack, after the crisis. Now, underneath this is medical coding. Every diagnosis has a billing code. It's how care gets paid for, but more importantly, it's how we count what's happening to the patients. There's a code for menopause. Perimenopause doesn't have one. It gets logged as unspecified. And what we can't count, we can't study. The busiest years of this transition for many are invisible in our own data. And then there's the cost of treatment. Almost every time I speak at an event on menopause, a woman finds me after to tell me the same story. My doctor offered me hormone therapy. I took the prescription to the pharmacy and didn't pick it up. Not out of fear, but against groceries and other family necessities, it seemed like a luxury item. And she isn't imagining it. List prices for these medications are up 58% in the last decade. And even when she can afford it, she may not be able to get it. Since the FDA lifted that black box warning, demand for estrogen patches has outpaced supply. Pharmacists have reported shortages all year. A system that spent 20 years telling women no wasn't ready when it finally said yes. Now remember Linda, no one failed her on purpose. It's that no one was trained to see what was right in front of them. And Linda isn't one woman. As you've heard, 75 million in this country are in perimenopause, menopause, or beyond right now. Every woman who lives long enough will join them. Linda is all of us. So here's the problem in 3 parts. We don't train the doctors to see it. We don't code it, so we can't study it. We don't cover it, so women can't afford it. A universal transition, and at every step, the system looked away. This isn't a mystery anymore. It's a decision about whether we build the system that half this country will need. Thank you.
Thank you, Dr. Berg. Menopause education for physicians could be expanded through policies such as Congresswoman Fouché's Menopause Education for Medical Students Act, and we have her here in this video. Thank you.
Good afternoon. I am Congresswoman Valerie Fouché, the federal representative for North Carolina's 4th District. I am sorry I could not be with you live today, but I am grateful for the opportunity to share a few words. First, I would like to thank women's health advocates for hosting today's virtual briefing and thank everyone joining this important conversation. For far too long, menopause has been treated as a private issue instead of a public health priority. Yet millions of women in the United States are navigating menopause and the menopause transition right now, often without information, support, or quality care they deserve. Menopause affects nearly every aspect of health and well-being, from cardiovascular, bone, and brain health to sleep, mental health, and overall quality of life. It also has far-reaching impacts on families, workplaces, and our economy. Despite its widespread impact, too many women struggle to find clinicians with the training needed to provide evidence-based menopause care. That is why I introduced the Menopause Education for Medical Students Act. This legislation would help ensure that future physicians receive education on menopause during medical school so they're better prepared to recognize symptoms, understand treatment options, and provide high-quality, compassionate care to their patients. By strengthening medical education, we can help close long-standing gaps in women's health care and ensure women receive the informed care they need. But this is just one piece of the puzzle. We also need to invest in research, raise public awareness, and expand access to quality menopause care. I am encouraged by the growing attention this issue is receiving, and I want to thank today's speakers and everyone participating in this briefing for helping move this conversation forward. Together, we can build a healthcare system that better serves women throughout their lives. Thank you, and I hope you have a productive discussion.
Thank you, Congresswoman Fouché. And as you said, we also need more menopause research. And so for that, I'm pleased to introduce Dr. Roberta Diaz-Brinton. Dr. Brinton leads the Center for Innovation in Brain Science at the University of Arizona. She's an internationally recognized for her research on why women are at greater risk of Alzheimer's disease. Thank you, Dr. Brinton.
Well, thank you, and I'm delighted to join you all today in this remarkable testimony to Congress on behalf of women's health, and in my case, women's brain health. I'm a neuroscientist that has been conducting research on why women are at greater risk for developing Alzheimer's disease. And for that, I have to give a great deal of appreciation to Congress, who funds the National Institutes of Health, and particularly the National Institute on Aging, who decades ago committed to understanding why women are at greater risk for developing Alzheimer's disease. There has been funding, and the National Institute on Aging has led the way. However, that's less than 1% of NIH funding to menopause research that affects half the population. And that has impact for what the world, physicians and science and women understand and are educated about the menopausal transition that is published in the scientific literature and in the clinical literature, but also then becomes communicated through our news reporting. 8.8% of total NIH spending went to women's health. And I think that's an underrepresentation of the importance of women and women's health in the nation. I do want to make again the point that the NIH, the National Institutes of Health, are the primary funders of women's health research. And the NIA has been very devoted to funding research to understand why women are at greater risk for developing Alzheimer's disease. We're focused on now, the information we're focused on now is really around what we don't know. And part of that is around infrastructure. And that infrastructure that was built decades ago has not kept pace with the challenges of today and with the advancements in population science and data science. Some of that evidence that was built decades ago was built largely on men and not on women. So we need to increase the representation of women in those data sets. There have been persistent inequities, the research gaps that were spoken about earlier around women of Black, Hispanic, and Indigenous Native peoples essentially are underrepresented in our data. And an issue that I'm working on persistently is around personalizing treatment and the power of precision medicine for menopausal hormone therapy. So let's talk about the brain, because actually the menopause, while we experience it body-wide, is actually driven by the brain. The brain is the command center for both the reproductive hormones that regulate reproductive capacity, but also respond to those hormones like estrogen, like progesterone. And the brain initiates puberty and it regulates fertility. And it regulates and drives the menopausal transition and reproductive aging. So we think about reproduction through our reproductive organs, but the biggest reproductive organ that we have is actually the brain. So understanding women's brain health across the lifespan is essential. And the next slide shows the complexity that that brain undergoes. And this is, again, research that has been supported by the National Institute on Aging, and that during the perimenopause, there are very complex changes that are occurring, both in the ability of the brain to utilize glucose as its fuel, as well as in the immune system. And there's an immune activation that occurs in the brain during this transition. And this figure here shows some of that complexity, just part of the complexity. Now, what was interesting is the description of brain fog that was mentioned earlier. Well, that occurs during that perimenopausal transition, that inability to find the words that, you're looking for and to explain complex, situations like this. And then also it persists into the post-menopause. But what is occurring is something that we're quite concerned about is the increase in the immune system response that many women can experience and ultimately develop, that starts the development of Alzheimer's disease in the peri and postmenopausal years. Now, just for all of our listeners, what we have found is that, in fact, the hot flash, while we experience from our head to our torso, is actually a brain flash. It is releasing heat from the brain. And that is occurring here during that perimenopausal transition. So where do we need to go? What's the next big hurdle and the next challenge? And that challenge is to bring the principles of precision medicine to menopausal hormone therapy and to the menopausal conditions that have been described by Dr. Berg and others before me, that this is a complex, body-wide, brain-driven transition in women's life. And the investment that has been made thus far has been an investment that has catapulted us to a new understanding of the perimenopause and the menopause. And now we're at the position to take that understanding and to translate that into effective strategies to sustain women's breast and body and brain health. Thank you.
Thank you very much, Dr. Brinton. So many of us think of menopause as simply hot flashes, so we're learning how much menopause impacts brain health and the interaction. So thank you. So finally, we're going to hear, before we talk about how you guys can take action, we're going to hear from Congresswoman Chrissy Houlihan, who joins us by video.
Hi, everyone. I'm Congresswoman Chrissy Houlihan, and I represent Pennsylvania's 6th Congressional District. I'm sorry I can't join you in person, but I'm grateful to women's health advocates and to all of today's panelists for bringing sustained attention to an issue that has long been overlooked for far too long. I'm an Air Force veteran, an engineer, and the ranking member of the House Armed Services Military Personnel Subcommittee. And in that role, one of my most important responsibilities is to make sure that people who serve our country have the support and care that they need throughout their careers and after they leave the military. We ask women to serve under conditions that most Americans will never, ever experience. They endure extreme stress, toxic exposures, demanding physical environments, and increasingly combat roles. But we have never adequately studied how those experiences may affect menopause and perimenopause, and that needs to change. And that's why I introduced the Servicewomen and Women Veterans Menopause Research Act. For the very first time, this legislation would direct the Department of Defense and Veterans Affairs to examine how military service may affect the timing and severity of menopause symptoms. It would study the connections among menopause, mental health, and conditions such as PTSD. It would identify gaps in treatment and provider training, and it would require both departments to develop strategy for improving research and care. This is not a niche issue. It's a healthcare issue. It's a workforce issue. And for our military, it's a readiness and retention issue. When symptoms go unrecognized or untreated, women can be pushed out of careers they worked for years to build. Our servicewomen and veterans should not have to choose between managing their health and continuing to serve or work. Military service affects women's health. Our research, our medical training, and our care must account for that service and its impacts on our bodies. Congress should pass this legislation, and we should finally give servicewomen and women veterans the answers and care that they have earned. Thank you for your advocacy and for including me in this important conversation.
Thank you, Congresswoman Houlihan. So now we've heard from all of these amazing speakers, and where does that leave us? Well, we're starting to see some change. It's starting in the states. All across the country, change is happening and people are speaking up. States highlighted here on this map in purple, each of these states has introduced one or more pieces of menopause legislation within the last 2 years, totaling more than 60 different menopause bills, at least 15 of which have already become law. So with activity in more than half of all of our states, red and blue alike, improved menopause care may be the one thing that we can all agree on. So among the popular policy reforms are those that mandate insurance coverage, workplace protections, clinician education, and public awareness. These are all topics we've discussed today and all topics that deserve legislative support. But the problem is really that this is a patchwork of uneven bills. They've been introduced state by state. So what we need to make sure is that women everywhere, regardless of where they live, they have access to the good care that they deserve. And really, only federal action can guarantee that. So let's look at how federal policy could bring better menopause care to every woman in America. There are 6 bills before you. These would invest in menopause research, which, as we've heard, has been critically underfunded for far too long. They would protect women in the workforce and ensure that the unique needs of veterans and servicewomen, as Congresswoman Houlihan just told us, these need to be considered. They ensure that all women have access to evidence-based care, not just in major medical centers, but in community health centers, in rural cities, in rural areas, really across the country. The bills ultimately would lower healthcare costs by educating the public and training clinicians to treat perimenopause and menopause not as conditions to endure, but rather as windows of opportunity to assess disease risk and to act proactively. The bills address our brains, our bones, health span, our longevity. They're complementary, they're not competing. So together, they really provide the infrastructure that we need. So we're going to ask you to take action. If you're a member of Congress or if you work for one, please co-sponsor one of the bills. Please fight for it. Join us on the Capitol Hill. We're going to be live. We're going to be in person on September 22nd for our perimenopause and menopause congressional briefing. That is open to everyone. We're going to lay out our recommended changes to reimbursement policy then. We also ask that if you are a member of Congress or you work for one, that you co-sign Congresswoman Dingell's letter to HHS requesting clarity on the estrogen patch shortages. Dr. Berg mentioned these when she was speaking. Women everywhere are having difficulty getting treatment because they are in short supply. So if you're someone who's watching as an advocate, if you're someone who is tired of us spending billions of dollars on preventable long-term health conditions, if you want better health care for half of our population, please tell your members of Congress that you support these bills. And the way to do that, this is your civics lesson, every person has 2 senators and 1 representative. So if you go to womenshealthadvocates.org, you can email all 3 at once in support of all 6 bills in 1 click. So we've made it very easy for you. And we'll put that in the chat and send it to you in an email afterwards so it's easy to find that link. And you are also invited to join us on September 22nd for the live perimenopause and menopause congressional briefing. So with an issue on this scale of this magnitude, we need each and every one of you to be engaged in this advocacy and to be aware of the consequences of inaction. 75 million women, including the women in your lives, your wives, sisters, mothers, and grandmothers, we thank you.